Yeah, so there's been three key clinical trials presented in the last 12 to 18 months, looking at the combination of PARP inhibitors and androgen receptor pathway inhibitors in first-line metastatic castration-resistant prostate cancer. So these trials build on the PROfound clinical trial that showed that the PARP inhibitor olaparib, and used as monotherapy in heavily pretreated prostate cancer, was associated with clinical benefit, with improved overall survival and delayed radiographic progression-free survival and other improved secondary outcomes. And so the premise behind these three trials was to combine PARP inhibitors, and there were different PARP inhibitors used in the three trials that I'll mention, in combination with either abiraterone or enzalutamide, which are the androgen receptor pathway inhibitors. And the premise behind these trials was really to look at whether the combination was more effective than the hormonal agent with the androgen receptor pathway inhibitor overall, but also to look at whether there was a benefit only in patients with selective mutations in the BRCA genes, or more broadly, homologous recombination repair, which is a DNA repair set of genes, or whether the benefit was seen in an all-comer population. So we know from the PROfound clinical trial that the benefit was largely in BRCA-positive patients, and maybe there was some benefit in other non-BRCA homologous recombination repair mutations as well. And so there were three clinical trials that we summarized at ESMO in one of the symposiums. And those three clinical trials are PROPEL, which looked at abiraterone plus olaparib, PARP inhibitor. There was Magnitude, which is abiraterone plus niraparib, another PARP inhibitor, and TELAPRO-2, which looked at enzalutamide, so different androgen receptor pathway inhibitor, but similar to abiraterone effectively, plus talazoparib, which is another PARP inhibitor. And so there were some differences between these trials and their design, and they're complex to go through. But essentially what we saw is that in all three clinical trials, the combination of the androgen receptor pathway inhibitor plus the PARP inhibitor was superior to the androgen receptor pathway inhibitor alone in BRCA-positive prostate cancer. So that was across all three trials. All three trials had radiographic progression-free survival as the primary endpoint, I should add. And in actual fact, for even in the homologous recombination repair deficient or mutated population, so that includes BRCA as well as non-BRCA mutations, there was a benefit in all three trials as well. And in terms of delaying radiographic progression-free survival. Where the trials differed was that the PROPEL and TELAPRO-2 clinical trials suggested there was a benefit in terms of radiographic progression-free survival in an all-comer population, so even in patients without mutations. The Magnitude trial did not suggest that. But what we've also seen is that overall survival benefit seems to be restricted even in PROPEL and TELAPRO-2 to patients with BRCA and homologous recombination repair mutations, and not in an all-comer setting. So I think that the takeaway message from this is that these three trials are all positive. The combination of an androgen receptor pathway inhibitor plus a PARP inhibitor is beneficial in BRCA-positive patients, in non-BRCA homologous recombination repair mutations as well. But the benefit in patients in an all-comer setting without these mutations is less clear, and there's probably a subgroup of patients within that who may benefit. But all three trials have led to regulatory approval of these combinations in either BRCA and/or homologous recombination repair deficient prostate cancer. So these are three landmark trials and have certainly changed our clinical practice, and will do so increasingly as we move forward.